Hi, my name is Karen Bears, and I'm an associate professor in the Department of Psychiatry and Behavioral Sciences at the University of Washington. I'm also the RUBI Clinic Director at the Seattle Children's Autism Center. Today I'm going to be talking about parent training for disruptive behaviors in autism spectrum disorder, and I'll specifically be focusing on the RUBI parent training program. Objectives for my talk include discussing the rationale for parent training as a frontline treatment for youth with autism and disruptive behavior, summarizing content of the RUBI program, as well as methods to personalize implementation, and then reviewing findings from a large-scale randomized clinical trial of the RUBI program, as well as future directions and research. So I want to start with a good news, bad news story in the field of autism. The good news is, compared to even a decade ago, we're getting better at identifying youth with autism, and that's a product of better screening methods, better diagnostic tools, and better community awareness. Put simply, if a family has heard of autism or has a sense of what it might be, they're going to be more inclined to bring it up at their child's next visit with their pediatrician, and that might set the steps for them going forward with some sort of diagnostic evaluation. So good news, we're capturing more kids and identifying more children with autism. The bad news is we have a bit of a pipeline problem. At least in the United States, we have lots of kids that are getting a diagnosis of autism, but they're getting stuck between the assessment and treatment pipeline. So it results in a lot of our families getting that diagnosis and then sitting on wait lists for 6 months, a year, 2 years. I've had families waiting 3 years for access to evidence-based treatments for their child who has autism. And this is of concern because when we look back at what we recommend in that diagnostic eval, we're saying the more treatment, the better. The sooner the treatment, the better. And so we are creating this challenge for our families that we're giving them a diagnosis and not, in turn, providing them access to the treatments, the very treatments that we're recommending that they receive. This also is compounded with just parents having to take in a lot around their child's new diagnosis. I say parents are often overwhelmed by understanding what treatment for autism is. Parents in the United States, they're very inclined to go on Google or the internet to do some research on what treatments for autism might be. And the reality is when they do that, they are, again, overwhelmed with the information that they receive. To speak to the pipeline problem, we have to first understand what standard or evidence-based treatments we're recommending for our families. And the gold standard in the United States is applied behavior analysis. ABA is great. It has lots of evidence to support its efficacy, but we also know that it is a very costly, time and personnel-intensive intervention service. When we talk about a child getting ABA services, we're talking about 15 hours a week, 20 hours a week, up to 40 hours a week of kind of a combined service package. And so when you're talking about interventions that are that costly, time and personnel intensive, it's going to create problems around wide-ranging dissemination. There's just not enough therapists available in the community, and there are certain pockets of our communities that have no providers available. And so we have this challenge of families really struggling to access these services. This is a known problem in our field, and the answer could be just getting more providers out there that will help. But I think we also need to look at other angles for solutions. And what has come into the field as of late is this idea to expand the availability of certainly empirically supported treatments, but also, almost more importantly, time-limited and cost-effective treatments for autism. And these are the avenues that will help expand the availability and reduce some of these access problems that our families are experiencing. This is where parent training comes in. Now, parent training has a very long history as an established evidence-based practice for youth, specifically with challenging behaviors and without autism. And when you look at available programs, you can find, Iberg's Parent-Child Interaction Therapy, Kasman's Method of Parenting, Barclay's Defiant Children Program, Carolyn Webster Stratton's Incredible Years program. So there are lots of great programs already out there that essentially demonstrate providers can train parents to become the therapist for their child. And particularly, the evidence is most strong in teaching them to be the therapist for their child when their child exhibits challenging behaviors. Now, what's valuable about parent training is it is traditionally a time-limited approach. When you look at the service models, it's 1 hour a week of outpatient therapy, up to 3 hours of outpatient therapy, and really the bulk of the work is the parent then going home and applying what is learned in the context of those time-limited therapy sessions. So it's time-limited in terms of the number of hours per week. It's also time-limited in terms of the overall course of treatment. And so when you look at traditional parent training programs, it's a 10-session program, 15-session program, 20-session program. And that's just to say that there's a beginning, middle, and end of each of these types of intervention. So when you have a time-limited intervention in terms of the hours per week and the total course of treatment, you're talking about an intervention approach that's going to naturally allow more people to be seen at one time in order to provide care. I think most importantly is what parent training is all about, which is that it emphasizes the role of the caregiver to be the agent of change for their child's behavior. I tell families, you can have your child come to me, I can work with them for an hour, they'll probably do beautifully in the 1 hour I'm with them, and then I send them home. And the question is what happens the other 6 days and 23 hours. So the idea that we can help the parent become the therapist for their child, that's naturally going to multiply the number of hours of intervention that a child gets in any 1 week. Essentially, a parent can be a therapist, in theory, all day, every day. So other reasons why targeting parents, and specifically parents who have a child with autism, is of value. What we know about this population is that there are pretty significant rates of challenging behaviors in this population. Upwards of 50% of kids with autism exhibit challenging behaviors like tantrums, noncompliance, inappropriate language, self-injurious behavior, etc. And so day in and day out, our families are dealing regularly with the blowouts, the meltdowns, the tantrums, which can be very, very stressful and can really interfere with family functioning, community functioning, social functioning, and academic functioning. Another important intersect, though, with these disruptive behaviors, specifically for our families, is the intersect between the presence of the disruptive behaviors and adaptive skills deficits. What this means in practice is a child who is told to get ready in the morning, go get dressed for school, for example, may refuse, may have a tantrum, and so ultimately they are not independently going to engage in that skill of getting dressed. And so what that means on a measure of adaptive skills, that child is going to have a lower profile, because adaptive skills is not what a child is capable of, but it's what they actually do day in and day out in terms of skill practice or daily living skills. What's interesting in our population, we also tend to see this pretty noticeable gap between cognitive functioning and adaptive skills deficit. So that's where this is kind of manifesting. And what I mean by that is we might have a child with an IQ of 100, 120, even 140. But when you look at their adaptive skills scores, it's going to be in the 60s, 70s, or low 80s. And so what that means is that child is exhibiting a gap between what they are capable of, if we use cognitive functioning as that metric, in relation to what they're actually doing in practice day in and day out. There's a gap. And again, we would argue that disruptive behaviors, or the presence of disruptive behaviors, plays into why that gap is present. That would then suggest that if you can address the disruptive behaviors or improve cooperation and compliance, you're also going to impact the implementation or the independence around daily living skills. And so reducing disruptive behaviors should produce an uptick in those adaptive skills. Our families are also, as I mentioned already, very stressed. And interestingly, there's some literature to suggest that the most stressful part of raising an autistic child is not the core symptoms of autism, but the commonly co-occurring challenging behaviors like the tantrums, aggression, self-injurious behavior. And in fact, our parents are more stressed than any other parent population. So if you looked at parents raising a child with autism versus another developmental disability, you'll see that our parents are scoring higher on ratings of parent stress. How this manifests oftentimes in practice is our parents engage in very high rates of accommodation, which means in practice, day in and day out, they tend to do a lot for their children as a way to avoid setting their child off into that disruptive behavior. I oftentimes hear families talk about feeling like they're walking on eggshells. They worry what's going to set their child off. It feels very unpredictable. And so to avoid that, they do a lot of work for their child. An example in practice, I had a parent who had a kindergartner who had average cognitive functioning and no significant motor skills deficits. And yet every morning, the parent would sit the child on the couch, put a TV table tray in front of them, put their breakfast on that tray, turn on the TV, and then proceed to dress and feed the child while the child watched the cartoons. And this was the mom's understandable way of just getting through the morning without a blowout. Lastly, when we look at the way that treatment unfolds, and this is kind of a historic perspective, families are not always included in treatment. In the United States, again, it's not uncommon for parents to talk about dropping their child off at the speech therapist and then picking them up when it's over, or even if an ABA therapist is in the home, the therapist and child are in one room and the caregiver is in the other room, and there's not always this kind of adequate synergy or connection between therapist and parent to ensure that there's skill generalization when the therapist leaves the room or the home. Now, what's encouraging is there has been a very exciting uptick in the amount of parenting intervention specifically for youth with autism. So I think there's a movement away from this parental exclusion, but it is something that a lot of our families are currently encountering when it comes to learning about the therapies that their children are participating in. So there are a lot of commercially available parenting programs already out there. I mentioned parent-child interaction therapy, Incredible Years, et cetera. And then you have programs that were also developed from the ground up for youth with autism, and that's where the RUBI program comes in. There's another program out of the UK called Predictive Parenting. My colleague in California has developed a program called Aim High. If you looked at all of these parenting programs, whether it was, developed originally for children without autism and applied to children with autism, or developed from the ground up for children with autism, you'll find kind of common features in these interventions when specifically targeting challenging behaviors. And these are some core components that you would expect to find in these programs. The first is that there is discussion and training around just how to improve the relationship between the parent and child. This is your non-directive child-led play, your use of catching the child being good, and praise. So essentially social attention to target the growth of positive behaviors and ultimately improving the relationship between the parent and child. This should be a core of any good parenting program. You'll also see training around how to set up a good reinforcement contingency, or the use of a token economy system, which might be like a point chart or a sticker chart. The use of consequence strategies like planned ignoring and compliance training, and then timeout. I will note that depending on what program you're looking at, timeout may be a core session, or it may actually be a supplemental session. So in the RUBI program that I'm going to be talking about, timeout is actually a supplemental session. It's not something we teach to all families. It's really brought in if it is appropriate for that particular child and family circumstances. So those are the components we hope all programs have, and that you would find in any good commercially available parenting program. What I want to add is what should also be in a program for youth with autism. And the first is incorporation of principles based on applied behavior analysis. This is the therapy approach that has the most evidence to support promoting change in challenging behaviors, for example, in youth with autism and other intellectual or developmental disabilities. This particular model promotes this idea that we can understand behaviors by understanding what happens around the behavior. And then using that information to ultimately try to understand why the behavior is happening. So a behavior like hitting, we would want to know what set that behavior off, which would be the antecedent, and what followed that behavior, which would be the consequence. So a parent says, go brush your teeth, and the child starts hitting. That demand of brushing your teeth would be the antecedent, and the consequence might be the parent walking away because they don't want to get hit. So the consequence of the hitting would be walking away. We would use that information to ultimately, again, try to understand why the behavior is happening, or we call it the function of the behavior. And we would say that there are kind of four main reasons why children engage in challenging behaviors. They're trying to get away, avoid, escape, something, like a demand. They're trying to get access to something, like the parent who tries to take the tablet away and the child hits. That hitting is trying to communicate, I want that back, or I want to get access to that. Behaviors can happen because the child is trying to get attention. And again, we can note that attention can be positive or negative. And for our children, there may also be an automatic function, which just means the reason the behavior is happening is not in relation to what's happening in one's environment, but what's happening inside the child, if you will. The examples of this are children who, for example, engage in hand slapping because it creates a very pleasurable sensation inside, internally. Or a child who hand slaps because they're feeling very agitated or anxious, and that hand slapping calms themselves. It reduces an unpleasant sensation inside. Ultimately, we would say, again, that automatic function is about how it changes how the child feels from a sensory perspective, a physiological perspective. When you look at applied behavior analysis, one approach that is important is this idea that we can use our understanding of the behavior to try to support the child, to implement strategies that create, a reduction of the events that set behaviors off, or work to support the child to be more successful, and to counter concerns about ABA being kind of a punishment-heavy approach. The ABA of today is really about setting children up for success and setting the environment up for success for the child. Another important aspect of parenting work for youth with autism is to talk with parents about the impact of setting events on the presence of challenging behaviors. And what we're trying to get at is, in traditional parenting programs, we think of behaviors as coming out of oppositionality or defiance. I just don't want to do that, and I'm protesting that you want me to do something that I don't want to do. And we get tantrums and aggression because of that defiance or non-compliance. And that can be the case for youth with autism, but what we also know is that youth with autism can engage in challenging behaviors because of things that don't have anything to do with defiance, and have more to do with experiences they're having in relation to feeling anxious or overwhelmed, a sensory experience that is really aversive, or if we think about core symptoms of autism, some aspect of rigidities that makes it difficult for a child to do something, and a push to engage elicits challenging behavior, or feeling overstimulated. One thing I like to talk with parents about is to understand the child's behaviors in relation to the difference between can't behaviors and won't behaviors. A won't behavior is, I don't want to do that. That can be that more I know what's expected, I could do it, I don't want to. Versus the can't is, actually I may not know what's expected, but if I do know what's expected, it still may be very difficult for me to engage in that behavior. So, for example, a child who is working on, a Lego design, and the parent comes in and says, okay, put the Legos away, it's time to go. And for that child who tends to have some rigidities, it may be very difficult for them to stop without finishing some aspect of it. And it's, again, framed in the, I can't because I need to finish this, not just I don't feel like stopping my Legos. And when you see the behaviors in those scenarios, I would argue that the expression feels more like an expression of distress versus defiance. So it's important to think much more broadly about what is contributing to behaviors in our population, or how we understand those behaviors. In terms of strategies, along with the things mentioned earlier, the reinforcement, the special time, the planned ignoring, again, a lot of work can be done around setting our kids up for success, and the kind of basket approach strategies for that are called antecedent management strategies. If we can understand what sets a behavior off and change or eliminate that trigger, then we're gonna change the behavior. We're gonna avoid setting the behavior off in the first place. And so we talk a lot about The use of things like visual strategies or cues. We know that a lot of our kids do better when they can see what is expected of them versus just being told. It might be being mindful of what we ask in the first place. We talk about doing things in small doses. So don't tell a child to go clean up the room. Go tell them to put that one toy in that red basket. It could be changing the order of events, making sure that less preferred activities are happening before more preferred. It's much harder to get a kid off screens to do homework. It's much easier to tell a child once you get your homework done, then you get your screen. And again, we would say all of that could be folded into the use of visual cues to help clarify. So like that visual, the first work, then play. We also talk about functional communication. Again, if we go back to this idea of applying the antecedent behavior consequence model and understanding that behaviors serve a function, we would also in parallel say that behaviors are a form of communication. When your child is hitting, when they're screaming, when they're pushing, when they're running out of the door, they are trying to tell you something. Our job is to figure out what are they trying to communicate through that behavior. And what's really cool is if you can better understand what the behavior is trying to communicate, that opens the door to figuring out what to do about it. So in practice, I say, to a parent, when your child is screaming, ask yourself, what is my child trying to say through that behavior? If they're saying, I need help through that behavior, well, then we can do something about that. If they're saying, I need a break, we can do something about that. If they're saying, I want more of that, we can do something about that. So at its core, if we can understand what the child is trying to communicate through that behavior, it opens the door to change how we set them up for success or give them a more functional tool to communicate what they want and what they need. Lastly, this ties back to what I talked about earlier, that intersect of challenging behaviors and adaptive skills. If we can reduce challenging behaviors, we should be able to then in turn push back in more of those skills that we want to see in practice. Getting dressed independently, brushing teeth independently, bathing independently. And so in the program that I'm going to go over, the RUBI program, you'll actually see that's built into the curriculum. We spend the first several weeks talking about strategies to reduce challenging behaviors, and then we cap things off with how do we now push back in skill acquisition. So that's a great primer for what I'll be talking about the rest of our time, which is the RUBI Parent Training Program. As I just mentioned, the RUBI program is we'll call it a twofold program, where we have two primary targets in the intervention. The first is to teach the parent strategies that are designed to reduce challenging behaviors, like non-compliance, tantrums, aggression, difficulties transitioning through the daily routine, et cetera. But we also have this push in for increasing adaptive skills. This is an outline of the RUBI program. It's an 11-session program that we want all families to get. We call those the core strategies. And what I want to point out is it follows the ABC, or antecedent behavior consequence model. So we start by literally teaching the parents the ABCs and having them go home and collect data on their child's behaviors and functions. We then move into sessions on antecedent management. So how do we prevent behaviors? How do we use schedules and visuals to help support transitions during the day? We then move on to the consequence side and talk about reinforcement, plan ignoring, how to support following directions. And to be very clear, compliance training, as I teach it now, I say it's less about the kid and more about the parent. There are things that parents can do to help set kids up for success with listening and following instructions. And if the parents can use those techniques, we might have a better job with following through on the child side. The last few sessions, as I mentioned, are about skill building, how to promote more functional communication, how to build back in some of the skills that we want to see more of. In the original curriculum, we do have home visits and telephone booster sessions that can help enhance implementation of those 11 core sessions. I also want to point out that we also have 7 supplemental sessions. These are more topical, but what we know is a lot of kids with autism also have these targeted challenges around, feeding issues, sleep issues, and toilet training, as they are the most common. And to treat those areas, you need to use or rely on those core behavioral strategies or principles. So we can teach parents the core strategies and then talk about how to apply them with a topical issue like sleep. So I want to talk a little bit about what a prototypical RUBI clinic case is. So while I'm certainly very biased, I think this program is great, I also know there are kids that are appropriate and there are kids that are not appropriate for RUBI. Again, it is a parent training program. It's traditionally an outpatient program where it's, one-on-one with the parent and the therapist. And so we know the bulk of the work is going to be happening on the parent's time without therapist support. So we want to be mindful of how we set families up for success, or more importantly, don't set them up to create unsafe situations. And so with that, with safety as kind of the number one driver for, is this an appropriate RUBI kid? We've landed on thinking about kind of 3 to 10 years of age as kind of the sweet spot, although I have done RUBI with kids older, 12, 14. I've even done RUBI with caregivers of autistic adults, but I've been very mindful about application in relation to safety. The target behaviors are those mild to moderate disruptive behaviors like tantrums, aggression, noncompliance. I say mild self-injurious behavior and inappropriate language. The key thing I want you to think about is the difference between aggression in a 5-year-old and a 15-year-old. I feel more comfortable talking a parent through how to implement strategies safely with their 5-year-old that hits. I would not feel comfortable doing that with a 15-year-old that hits and can actually create real harm to self or others. I don't want to put a parent in that position. We do need a caregiver who can attend regularly. The good news from the research that we've done on RUBI is we know it can work for a broad range of youth with autism and a broad range of cognitive functioning. In practice, it means it works just as well for a nonverbal 3-year-old as it does with a very verbal or hyperverbal 10-year-old. We do like to think of receptive language criteria as kind of a cutoff. If a child has really impaired receptive language, I would argue they're really needing a different type of intervention, really focusing more on core skills than targeting the challenging behaviors at that point in time. In terms of exclusionary criteria, I think there can be too much of a good thing, if you will, and for a family that maybe has just very mild, very focal behaviors, like it's only during the morning and it's this one thing, that 11 sessions might actually be overkill or too much. I also think children who are engaging in very focal, challenging behaviors like pica, elopement, and encapricis, that they are better served with a more focused intervention program. Because RUBI, again, is more broad. We're teaching parents lots of strategies for lots of different types of behaviors. And I'm going to end where I started, which is that implementing RUBI, safety should be number one. And so if you have a child who's engaging in behaviors that are resulting in hospitalization or tissue damage, or are at risk of doing that if you teach the parents the strategies and they go home and apply, then I would say that is not an appropriate RUBI case. We do in our practice have kind of a screener form that we have providers fill out just to help ensure we are getting the right kids in the right service. And so we ask things like, does the child have autism? What's a kind of an estimate of their intellectual abilities? What's their communication skills or systems? What are the specific behaviors that are of concern? And where are the behaviors present in the home, at school, out in the community? And so if I see a child who has an autism diagnosis with an intellectual delay, only uses an augmentative device for communication, engages in self-injurious behavior and pica, I'm not going to put them in the RUBI program. I'm going to refer them to my colleague who does more intensive services. But this is a really simple way for providers to kind of look at who's being referred to the program and make sure we're doing an appropriate screening and referral process. The RUBI program is designed, it was initially designed to be delivered one-on-one, so a therapist to a caregiver or caregivers. The beauty of the RUBI program is it's a pretty structured intervention. It has 2 books. There's a clinician manual that has the therapist scripts and some fidelity checklists. And then there's a separate parent workbook that I give directly to the parent that has all of the activity sheets we're going to go over, the video vignettes that we use to help with teaching strategies. And there's a summary handout at the end of every session that kind of goes over what we talked about, so the parent has that for reference. A big part of the RUBI program is homework strategy development. I'll talk more about that in a little bit, but the idea is that we kind of teach a strategy like visual schedules, and then we work together with the parent to figure out for this particular child, how are we going to apply this particular strategy. So there's a lot of tailoring and personalization of the implementation of the intervention. This is literally a screenshot of the therapist, a page from the therapist script. I just want to show this to demonstrate literally how structured it is. That every session has a set number of goals, usually 7 to 10 goals. And then there's kind of a little bit of a scaffold for how one might explain the goal through the therapist script. I want to be very clear. We do not expect therapists to sit there and just read the script, but it is there for providers who may need some assistance or support in how to explain a particular goal. And so the level of scaffolding through the therapist script does increase accessibility for providers who may not be as versed in behavioral principles or who may benefit from having some again, scaffold or support in how to deliver the content. This is an example of an activity sheet that would be in the parent workbook. This is in relation to talking about reinforcers with our families. So we might teach a principle and then spend some time discussing the principle in relation to their child and how does it apply. So this is like talking with parents about like, oh, does your child have any unusual preferences that could be a reinforcer? What are kind of naturally available reinforcers in the home? What are privileges that might be useful for a reinforcement contingency? So this is the ability to discuss a principle or concept and then talk about application with the families through the use of these activity sheets. We also have video vignettes that create learning opportunities as part of the discussion. Oftentimes in the video, the parent is doing something not correct, and it creates a pointed discussion between the therapist and parent about like what went wrong, what suggestions would they have for the family. It really, again, gets to supplement what we're kind of teaching them in terms of content. And I think importantly, the videos also create an opportunity for us as a therapist to get a sense, is the parent getting what I'm talking about? Like I just talked about 8 prevention strategies. Are they able to take that content that I just taught and apply it in this video vignette that's demonstrating, you know, how prevention strategies could be used? And if a parent really flounders or has a hard time with the videos, I know I need to go back and supplement my instruction. So I'm just going to show a video that demonstrates a child who's having some behavioral challenges and how the parent responds.
Here. Peanut butter and jelly, come on. Sit up.
Chicken nuggets.
No, I'm not having chicken nuggets.
Chicken nuggets. Chicken nuggets.
Sweetie,
Chicken nuggets.
We are not
chicken
having.
nuggets.
You had chicken
Chicken
nuggets
nuggets.
yesterday.
Chicken nuggets. Chicken nuggets.
Peanut
Chicken
butter.
nuggets.
Look at this.
Chicken nuggets.
This is your favorite kind. Mommy made it for
Chicken
you.
nuggets. Chicken nuggets.
Look at me.
Chicken
Look at me.
nuggets.
We're not having chicken nuggets again today.
Chicken nuggets.
Chicken. You can't have that every day.
Chicken nuggets. Chicken nuggets. Chicken nuggets.
Okay. All right, fine. All right. Go get you some chicken nuggets.
So we were showing this video to families to help talk about inadvertent reinforcement of problem behavior. So we would ask the parent, you know, what was the child's behavior? What set it off? How did the parent respond? And then ask the questions, well, what did the child learn from that? And also, what is the child likely to do next time? So we can, again, use these video vignettes to help talk through, demonstrate, problem solve the behavioral principles and strategies that we're reviewing in the RUBI program. Another really important part of the RUBI program is the behavior support plan. So this is a document that is blank at the beginning of treatment and is slowly and steadily built over time as we develop specific intervention strategies for that particular child. Because it is so tailored in terms of how we're developing strategies, I like to say that every child that I've ever worked with will have their own unique behavior support plan, because again, the strategies are about that child and what would work for them and how it would work for them. And we introduce the behavior support plan in the very first session, and then every week we're supposed to review it and update it. So really it is a document that builds over time and stands as this kind of summary document of all the interventions that we've taught through the course of the program. And ultimately at the end of the program, it is a all-in-one, you know, description of the strategies that can be applied for this child. This is just a screenshot of an example behavior support plan, and what you see, for example, are the strategies are listed in the left column, and a very detailed description of that strategy in practice is in the specific details. So, for example, a timer, and then how are we applying the timer with this child? changing the order of events? How are we applying it with this child? Lastly, I want to talk about how we bring RUBI to life. I can appreciate that because it is such a structured and manualized program, there is a sense of like, oh, I lose the creativity of therapy. It's going to feel very stifling, and I'm going to feel confined in the work that I do. But I want to go back to this idea that the work that really is happening in RUBI is this partnering between the therapist and the parent to think about how to apply the principles specifically for that family. I like to say in practice, I am a person who knows some stuff, has some strategy ideas. I'm the expert in some strategies, but the family is the expert in their family and their child. And so we should be coming together and partnering and co-constructing how we meld this strategy expertise and family expertise to identify what we even want to work on. And again, I like to say the family really should be the one that is defining the targets of intervention. And then I can provide information on some strategies that will help those targets, and we come together ultimately to create behavior change. It is a really, again, partnering and co-constructed process that unfolds, and it's why we land on such specific, individualized treatment planning and goals for any one particular child and family. So I want to transition to talking about the research on this program. I've hopefully built some excitement about this as a promising intervention. I can say clinically it sounds great, but that's only so far, that takes you only so far as whether it actually works in practice. And the good news is we can say that this is an intervention that has a large amount of evidence to support its efficacy in changing challenging behaviors and improving adaptive skills in youth with autism. So my colleagues and I conducted a large-scale randomized clinical trial on RUBI. We compared RUBI to just parent education, like just teaching parents everything about autism except how to address challenging behaviors. So educational planning, family advocacy, co-occurring medical conditions, different types of therapeutic supports, et cetera. So lots of information, just not how to treat challenging behaviors. And we focus on kids ages 3 to 7 years of age with autism and challenging behaviors. I will say that this RUBI program has also been studied as part of a medication trial. So it was medication only versus medication plus parent training. The medication was risperidone. And that went up to age 14. And RUBI, the combination treatment of RUBI plus medication was more effective than medication alone. So that's why we can say that RUBI can work with kids up to age 14. We have evidence or research to support that. And in practice, again, I kind of stick with the 3 to 10 years of age. This study was focused on the younger children, so as a standalone intervention without medication. This is a 24-week trial, and we followed the families very closely. Every 4 weeks, we were assessing how things were going in relation to challenging behaviors, adaptive skills, et cetera. And we also followed families at weeks 36 and 48, so 6 months post-treatment to see whether any treatment changes maintained over time. What we saw is that therapists were able to implement the intervention with a very high degree of fidelity, 97% fidelity to treatment. And just as an aside, that fidelity rate was just as high for the parent education, the psychoeducation program. We also had families that stayed in treatment. So again, this is a 6-month trial, and 89% of families randomized to RUBI stayed in RUBI. We only lost 11% of our families. Interestingly, in the parent education program, we only lost 9% of our families. So we had very high engagement in both interventions, but RUBI certainly in particular, and most families would recommend the RUBI program. What I want to highlight is this is a multi-site study. So we had 6 sites conducting the study, 23 therapists delivering the intervention, and yet we had 97% fidelity. And what that means to me is you can train a lot of people in the intervention and have high success with fidelity, which really is promising in relation to broader dissemination. When we look at outcomes, we had parents fill out the aberrant behavior checklist irritability subscale, and we had them fill it out every 4 weeks. And what we saw saw is that actually both groups got better, parent training, the RUBI program, and parent education. But that RUBI did better. RUBI is the orange line, and so what we see is about a 50% decline in irritability in RUBI versus about a 30% decline, and this is a statistically and clinically significant difference between the two groups. I have a line there at week 16 just to point out that the bulk of the intervention was actually conducted in the first 16 weeks, and week 16 to 24 was kind of a booster phase. And what you notice is the behaviors are actually still going down in that booster phase. I like to think this is parents kind of consolidating information, applying in different ways that is creating this accumulation of positive behavior change. We also looked at who got better, who was much or very much improved. This was an assessment done by a masked independent evaluator, so someone who did not know what treatment arm the family was in. And what we see is, again, both groups got better, but the RUBI group, which is the orange line, got significantly better. We had about a 70% positive response rate in RUBI compared to about 40% in psychoeducation. And again, that was not just, oh, they got a little bit better. These are families that were where the kids were considered much or very much better from baseline, or much improved or very much improved, from baseline. So we can say in practice that means if you have 100 families come in clinic for RUBI, about 70% of them should be significantly improved by the end of treatment. Lastly, there's always the question of, that's great, but do the findings stick around? Does a positive change stick around? And we have data to support this as well. These are the families that were RUBI responders. That's that 70% of families that were randomized to RUBI that were considered responders. So they got better at week 24. When we follow them out 6 months later, we see that positive progress, or that reduction in challenging behaviors maintained over time. We also have data to support that hypothesis around the link of disruptive behavior and adaptive functioning. What we saw is in RUBI, kids got better behaviorally. They also improved in their adaptive skills in relation to the families and the kids that got the psychoeducation. I mentioned earlier that RUBI can work for children across the cognitive spectrum and the autism severity spectrum, and we know this as a product of our moderator analyses that showed no differences in the impact of RUBI based on those factors. Lastly, we see that our parents who went through RUBI and parent education, both of them were less stressed, less strained, and had more competencies at the end of their programs, but the RUBI families did significantly better in terms of stress reduction, strain reduction, and competency building. What's exciting is since that large-scale clinical trial, we've expanded how we've applied RUBI and studied that. So we've looked at delivering RUBI via telehealth. We've also looked at delivering RUBI in groups. As I mentioned, it was initially developed as a one-on-one intervention, and then so we looked at what do you do when you apply it to a group of parents. And both studies had excellent outcomes in terms of the same findings of high engagement, significant reduction in challenging behaviors, and improvements in adaptive skills. The one note I'll put about intervention, or the groups, is that to be mindful of how big a group is when you're doing RUBI. The piece that I think makes RUBI work is that opportunity to individualize and personalize the homework strategies. And when you have too many people in the room, you lose that ability. I would say at that point, you're moving from intervention to psychoeducation. You're teaching people strategies, but not necessarily creating that opportunity for that individualized one-on-one follow-up. We've also had some really exciting expansions in RUBI. One is there's been the development of an app. So RUBI in an app form, and that's great because that means in theory, any parent can get their hands on the strategies that are taught in RUBI. I would argue that if we're just putting it in their hands, it is psychoed and not intervention, but it is a way to help parents learn about these different behavioral strategies. My colleague Jill Locke and I have also been working on expanding RUBI into schools, so teaching paraeducators how to implement RUBI. And we are in the midst of doing a community implementation project where I have been delivering RUBI clinically to families at Seattle Children's, and we're now looking at the data to see how those families compare to our clinical trial families. And this is what we've learned thus far with that data. This is the Seattle Children's clinical data, which is the blue line, compared to the RUBI clinical trial. And what we see in practice is that we are treating slightly older kids. About the same breakup in terms of cognitive functioning above or below 70. A more diverse sample, 64% Caucasian is still a high population of white families, but it is lower than what we saw in the clinical trial. We're seeing more kids on medication, and excitingly, we're still seeing low attrition rates at about 15%, which is compared to 11% in the clinical trial. When you look at outcomes on the aberrant behavior checklist irritability subscale, we see very similar reductions in challenging behavior in clinic practice as compared to the clinical trial. So to summarize, I just I appreciate that I'm a little biased in the value of RUBI, but I do want to point out, I think, the strengths that it brings to communities. First and foremost it is a low intensity, low cost evidence-based program which addresses those access issues I talked about earlier, those pipeline issues. Because it's a traditional outpatient service, it also allows an individual provider to have high clinical productivity in the context of that treatment model. I mentioned it's a structured and manualized intervention, which means it helps providers who are learning these behavioral approaches to have more success with implementation. I will say in the United States, at least, we're able to use a pretty flexible clinical implementation model with RUBI. So there's kind of a set of billing codes that I can use with RUBI implementation, depending on, for example, whether the child is in the room or not in the room. Again, it can be delivered in group versus individual. It could be in clinic, in home, or via telehealth. And we've been talking about where RUBI falls in the broader autism treatment spectrum, and whether it just lives as a standalone intervention versus it's something that's folded into ABA practices, while families are waiting for services, they get RUBI, or while they're getting ABA, they also get RUBI. In relation to kind of going back to the structured and manualized aspect of RUBI, it does open up the program to being implemented by providers from a variety of backgrounds and degrees. I have trained speech therapists, child psychiatrists, psychologists, master's level, PhD level, and kind of nurse practitioners everywhere in between. And so it speaks to this kind of accessibility of the program by various providers. And lastly, I would just say that it's not difficult to train providers in RUBI. I actually have a clinic that's run entirely by practicum students under my supervision. Obviously, doing webinars to train providers is great. And we also have this really cool network in the United States called the ECHO network, and there's actually an ECHO Autism network, which is about having a hub of providers that reach out to folks in the community, different community practices, to help disseminate training on the RUBI program. With that, thank you for your time.